Okay, the next P is powers, and these are really the uterine contractions mixed with the mom's pushing as she's in labor. So the contractions mixed with the mom pushing is what gets that fetus to descend and to birth that baby. So this will be a review for some of you, but there's one group that did not get to go to lab. So I'll just go over this very quickly. So we look at the cervix, and this is the very bottom portion of the uterus. And when we do vaginal exams, we're checking for these two things when we're thinking about the cervix. So the first one is effacement. So we like to see this long membrane here all through pregnancy to keep the pregnancy there and not lose the baby. But when a woman is getting ready to go into labor, about a couple weeks before she's actually going to go into true labor, her cervix will start effacing, and this means it's shortening and softening, and this is due to the presenting part of the fetus pushing against the cervix causes it to efface, and also the hormones of pregnancy. So the other one we think about is dilation. This is just how far open the cervix is in terms of centimeters. And we do not let a woman start pushing until she's 10 centimeters because there's risk of cervical laceration. So when a woman is about 5 centimeters dilated, she'll be 100% effaced. So effacement happens rather quickly, and dilation can take lots of hours. That will be the beginning of that. The second stage of labor is when a woman is completely dilated, or her cervix is completely dilated. Okay. So let's talk about the uterine contractions. These are involuntary muscle contractions that compress the uterus and add to the power of expulsion forces. So this is a uterus between contractions. It's nice and relaxed, and those uterine arteries are perfusing that baby nicely. And then during the contractions, everything is kind of squeezing, and you see this myometrial labor just kind of really forcing that baby down into the birth canal and helping birth that baby. So during early labor, the contractions are really mild. The woman is not in a lot of pain. It's more like the menstrual cramps that she gets. And the frequency is about 5 to 7 minutes when she becomes in true labor. And then when she's progressing in labor, the good contraction pattern we want to see is this. We want to see frequency every 2 to 3 minutes apart, and we want to see a duration of 60-90 seconds. So let's talk about the contraction. There is an increment or an increase in pressure, and then the peak is where the intensity is the strongest, and then a decrement where it decreases. And then there's this nice period of relaxation. And I talked about this in lab. This is so important to reperfuse that fetus. If you don't have this, then in cases of oxytocin, you'll see contractions coming right after one another. You're going to want to decrease that oxytocin or turn it off completely. Because if that baby starts to have an abnormal fetal heart rate pattern, then we can cause lots of problems to that fetus. And this is the problems that you see with the use of oxytocin in labor, is they don't get that period of relaxation. There are other problems too, but that's one of the main ones. So our external monitors, the Doppler that does the fetal heart rate, and then the TOCO, which does the uterine contractions, they can measure two things. They measure the frequency and the duration of a contraction. And I wanted to say that. So frequency is from the beginning of one contraction to the beginning of another contraction, not in the middle. We measure frequency from the beginning to the beginning. And then duration is just from the beginning of a contraction to the end of that contraction. So we can measure duration and frequency, but we cannot measure intensity. So if we're going to palpate that fundus, the very top of the uterus, and we're going to, when we feel, and it feels like the tip of your nose, that's what a mild contraction feels like. And then if you were to palpate touch the bottom of your chin, that's what moderate contractions feel like. And then to feel your forehead, you can feel what a strong contraction feels like. So the next P is the position, and this is the mom's position that we're talking about. We want to reposition the mom frequently to help get that baby moving down the birth canal. And we also want to help with pain. If we can reposition a mom and open up that pelvis and get that baby moving down, it helps with the progress of labor, and it helps with the pain. So here's some labor positions that are frequently used, and in other countries they give birth squatting, and you can see that it's so effective because it opens up that pelvis, whereas we give birth on our backs because culturally that's what we do, and 85% of the time women have epidurals anyway. But there's other reasons that we are going to do labor positions. If there's a posterior baby, meaning that occipital bone is facing the coccyx, so it's back towards the coccyx, we can do hands and knees or this Trendelenburg position to get that baby off of the back and help. The other really good thing that we can do is what's called counter pressure, and we'll talk about that when we talk about non-pharmacological pain measures. And the last P is psychological, and this has to do with the mom's psyche. A mom that is experiencing anxiety will release catecholamines that can actually decrease perfusion to the baby, increase time of labor, and cause her contractions to be inefficient. So if we do see inefficient contraction patterns, we're going to want to quiet the room, help her feel secure and stable, and decrease her anxiety. And if we need to, we can give her pain meds or any kind of sedation medication. So the next section here is the stages of labor. And in your assignment, I have you do a whole kind of chart, or however you want it to be. I just want you to think about, be able to differentiate between each stage and phase of labor and what the cervix is doing and what the mom is doing during those times, and also then what the nurse is doing. So that is the last part of your assignment for this labor and delivery. So this first stage is contractions are mild. It's the beginning, so not a lot is going on. The cervix dilates from 0 to 3 centimeters, and we're trying to get full effacement dilation of the cervix. So we're going to do Leopold's maneuvers because this is when the patient first comes into the hospital, and we do continuous fetal heart monitoring in the hospital. So we want to find that upper fetal back, which is where we put that monitor. And we're going to do a vaginal exam to see if the cervix is effacing and dilating, show true labor, and if there's rupture of membranes. So with rupture of membranes, always, always, always remember this, whether we're artificially rupturing them or if they're ruptured on their own, we're going to look for where that umbilical cord is. With a rupture of that fluid, it can cause the umbilical cord to come out first or be up against the fetal head. And if that happens, the umbilical cord is up there, during a contraction, it will cut off the umbilical cord completely. And this is called umbilical cord prolapse. And that is an emergency. You've got to get that baby out very quickly. I mean, within 5 minutes, you've got to get that baby out via C-section. So also what we're going to do is we're going to have that woman void frequently, because the fetus is not going to be traumatized, but the bladder can be traumatized. It also decreases the space of the pelvis, so it makes it hard for that baby to descend down the birth canal. And then we're going to take their temperature to see if there's any problems with chorioamnitis or any other kind of infection that we might need to treat. So let's talk about Leopold's maneuvers. This is a review for those of you who went to lab, but those of you who didn't, they are 4 different maneuvers because we're trying to see the position of the baby in relation to the mom's position. So the first one we do here, you can see, is we're going to palpate the fundus to see what part is in the fundus. Is it the head or the buttocks? Hopefully it's the the buttocks, because we want to have a cephalic or head down baby. And once we feel that, then the next one we're going to do is we're going to take our 2 hands down the 2 sides of the belly, and we're looking for that fetal back. Because we're looking for this part, this upper fetal back. And that's where we're going to place our fetal monitors to get a good fetal heart reading on our strips. On the other side, we're going to feel those appendages or the feet kicking in the hands. The third maneuver, we're going to see what the presenting part is. So we're going to kind of reevaluate what we learned from this maneuver. And hopefully you'll feel the head down here. You just feel it right above the pubic symphysis. And then the fourth Leopold's maneuver, we're going to check right here to check fetal attitude. So if a baby has a nice flexed head, that decreases the diameter, and also the molding that can happen that I talked about is going to help that baby come out, and it nicely opens up the cervix. If it's in military attitude or an extended attitude, that's going to increase the length of labor, because we know that the centimeter is greater, and it's going to cause, it's going to be harder to get that baby out. Okay, so this first stage is divided into 3 phases. So the goal of stage 1 of labor is to get that cervix completely dilated. So phase 1, this is the latent or early phase. It begins with the start of regular contractions that are doing something, effacing and dilating the cervix. So effacement is 0 to 40%. By the end, it'll be about 40 to 50%. Dilation is 0 to 3 centimeters, and then these contractions are happening about every 5 to 10 minutes. They don't last very long, 30 to 45 seconds, not minutes, and they're mild contractions. They are similar to menstrual cramps, and if it's 10 minutes apart, they're going to remain at home, and they kind of are excited at this point because finally they're going into labor, and by this time women just don't care. They want to not be pregnant anymore most of the time. Phase 2 of stage 1 is the active phase. We call this active phase because the cervix dilates to pretty wide at this time. The effacement is about 40 to 80%. Contractions are about every 2 to 5 minutes, lasting a little bit longer. This time women are a little bit more intense. They're inner focused, they're self-absorbed. They practice any kind of breathing, biofeedback, imagery. That's a good time to activate these kind of things. And you'll read more things in chapter 14 of your ATI that a nurse can do to help during this time. Frequent position changes helps to open up the cervix. And again, we're going to keep voiding a little more if she's not tethered. If she is tethered by an IV, or she has an epidural at this point, then we're going to give her a catheter. But we want her to keep that bladder empty through this every phase, until she's delivered. We do not want her having a full bladder. Phase 3, so if I can move this up, I can't move it up. So this last one here says phase 3, and this is we're still in stage 1, and this is the transition phase. This is the hardest phase. It lasts the least amount of time, but it is the hardest phase for women. So dilation, they're getting fully dilated, fully effaced. Most difficult, very strong, painful, and frequent contractions. There's a lot of pressure on the rectum because this baby's head is right down there during the rectum. She may have a desire to push. There may be vomiting at this time. She's irritable, restless. You can see her sweating and trembling. This is when a support partner, if she's going to go unmedicated, a support partner is really vital to help her get over this part. There's this feeling of overwhelmingness and loss of control, and we're going to teach this pant cleansing breath. You'll see that in the video that we have for you, the comfort measures. And this pant cleansing breath helps her not to start pushing. She cannot start pushing until she's dilated to a 10. So if you do this pant cleansing breath, it's hard to push at the same time. So that's why we want to encourage breathing. Okay, we're going to stop this video and continue with the next stage of labor.